Okay, so I think we should get started, right? All right. Great to see you, everybody. It's Friday before Memorial Day, so I really appreciate you being here. And this is the last series in this talk. And as you know, today I'm going to talk about a topic that is, deriving for sure from the management discussions we've had in the past 2 days, but is focused specifically on the role of management in the public sector. I want to motivate, again, why I think that this research agenda is important and it's relevant. Fundamentally, this, if you were here on the first day, you heard me talking about the vast differences in performance, productivity within the private sector, across countries and within countries, which are pervasive and to some extent not well understood. Well, it turns out that thanks to the availability of microdata, where we can track the performance also of public sector organizations, we are uncovering the fact that these vast discrepancies in performance also exist, if not to a larger extent, also in the public sector. So if you look at data on schools, value-added, student-level measures of results and value-added. If you look at hospitals, I'm going to focus on hospitals quite a bit today, measures that we all care about. For example, whether we survive a heart attack after we are admitted in a hospital, or even things that are, maybe not on the top of our minds, but bureaucracies, right? Procurement, buildings, World Bank managers, you name it. This data is showing that there are vast differences in performance even within the public sector. And I think that these are really important to study because in a sense these are organizations that touch us every day in our life. And I want to try and understand whether connecting these variances in performance to variances in management can sort of help us make a little bit of an advancement towards improvement the quality of these organizations. I also want to say that these organizations are also fascinating to study from a theoretical perspective because these are places in which formal levers, such as, for example, pay for performance, right, that you might use in private sector organizations to align objectives of employees with their principles, are actually really hard to implement and sometimes might even backfire. So I'm thinking of problems that I'm sure you have encountered, multitasking issues. Public sector organizations might have multiple objectives, and placing specific targets or compensations on one objective will and often does, create some distortions in attention. People put efforts in things that are easily measured or easily compensated, and they sort of leave behind things that are equally important but very hard to measure. Influence activities, for example, if there are subjective performance measurement, Milgram and Roberts have studied this extensively, you start getting into political economy stories within the firm, who lobbies best gets rewarded versus who's more capable. Multiple principles, since the goals are unclear because we don't have this sort of guideline of profit maximization. And also, it's important to consider the fact that public sector employees might be different in terms of their preferences. In 2 dimensions, at least. One is risk aversion, so the willingness to incur risk, and that limits, again, the type of incentives that you can use to motivate this type of agents. But also the fact that public sector employees might be, and often are, intrinsically motivated. And so there is an emerging and rich literature that is thinking about the ways in which traditional levers of alignment might actually backfire once you have intrinsically motivated agents. So this is just to say that understanding how we coordinate, how we manage public sector organizations is extremely hard because some of the tools that you might have in the private sector are not at your disposal. And so I think that that's where management becomes potentially a way through which you can, rather than using sort of formal contractual solutions, thinking about management as a possible lever. I find this idea, quite interesting. So what I'm going to do is I'm going to explore with you, first of all, the evidence that we have so far about, and I'm sure that I'm not going to do injustice to the literature. There is a lot that is coming out that might not be covered in this brief survey, but I want to cover with you, first of all, what do we know about the variation of management practices in the public sector and how that correlates with measures of performance, and then focus specifically on some work that I've been doing and other people have been doing specifically on healthcare and on hospitals. So let me start first of all with this idea of measurement. The question is, how can you possibly measure management in the public sector? Well, you've been victims of my talk for the past 2 days, so I think you know the answer, right? You can go in with what at least our approach has been to use the same type of methodologies that we had used in the private sector, a structured series of open-ended questions and a scoring methodology that we try to make as rigorous as possible. With clearly adaptations to the specific context, but using exactly the same type of methodology, simply changing, rather than talking with manufacturing firms, talking with schools and hospitals. And this has been our starting point. We've done it for 4,000 high schools and hospitals around the world. But it's been really amazing to see how other researchers have taken these tools and used these tools themselves, extending the measurement to nursing homes, for example, even universities, police departments, civil servants, and it keeps going. But the idea fundamentally is, let's focus on the basics. The basics will travel across different industries, and that's our basis for measurement. Once we apply, the highlight of this measurement exercise is that similarly to the private sector, we see that there is tremendous variation within countries in the quality of management practices. I'm going to show you some evidence on that. It's true that once you look at the public sector, the variation that is accounted for by country characteristics, where country signify basically the institutional context in which these public sector organizations operate, is typically larger than it is for private sector organizations. So the variance of, it's about 60% of the variance is accounted by these country differences, but there is still a ton of variation within countries. And in general, these scores, the level of management practices that we equate to quality, is behind manufacturing, especially in developing countries. We see a big gap and perhaps also a big opportunity in developing countries. And in general, we also find that these levels of management practices are correlated with metrics of performance, which in this case are not anymore financial, but actually are things such as I was saying, mortality rates, student performance, faculty satisfaction, and so forth. And other people have built on these cross-sectional correlations using experiments, which I'm going to describe in a moment. Just to give you a sense of the variation that exists across different organizations within different sectors within the country, within a specific country, I'm plotting here the distributions of this management score for schools, hospitals, and manufacturing in 4 countries where we are able to, where we collected this data with a meaningful sample. And there are a couple of things to observe. First of all, this is the point that I was making before. Overall, it seems like the public sector, the distribution of the scores is shifted to the left relative to manufacturing. So there is an element of gap in terms of adoption of management practices. There seem to be, similarities between education and healthcare. And the third point that I think is, really where a lot of action might be needed is this issue that, especially in developing countries, and here I brought as an example India, but it's similar also for other developing countries, there is this massive gap between public sector and private sector organizations. So I think this is really something to think about and something that deserves much more attention and potentially much more investment. How do you bring this sector of the economy back to, or how do you diffuse best practices in this sector of the economy? Yes, please.
Do examinations have a breakdown for hospitals by public and private hospitals?
Yeah, we have. I'm going to show you the graphs today. But, similar to the public sector, you see that there are differences. However, for example, in the US, getting at this distinction is not the easiest for various reasons. But, the bottom line is we do still see a difference between private sector organizations, private-run organizations and public-run organizations. Yeah. And then, when it comes to the outcomes, the other relationship that I wanted to briefly describe, just to bring you an example, in a recent paper that we wrote about schools, we saw that, perhaps to our surprise, schools that were well managed, meaning schools where the principal had a much more proactive attitude towards using data and measuring paying attention to the problems that would arise both in terms of teacher and student educational experience, in schools where the principals seem to be, according to our metric, better managers, we also see students getting better test scores. And clearly this is a correlational exercise. We can't get at pin down exactly the causation behind this correlation. However, people like Fryer actually were able to run managerial experiments within the state of Texas, and implementing an RCT that tried to replicate some of the aspects of these high-performance US charter schools, which other people had found to be important for educational outcomes. He was able to demonstrate that the implementation of basic managerial principles, such as the use of data to guide instruction, providing feedback to teachers, providing tutoring to students, and changing, if you like, the culture of the school, was associated with significant increases in math scores of the students. Now, it's also interesting because if comparatively, however, he also found that it was much harder to change the reading scores of the students, in partly because your attitudes toward reading are often imprinted on the kids before they reach the level of high school. But I think it's interesting because it sort of suggests that, even within these problematic organizations, there are some organizational innovations that might benefit the students. Other evidence that suggests the importance of management in the public sector comes from, I think, an ingenious experiment that was run by Anders Schleifer and co-authors, where they basically asked the question, how can we measure efficiency of postal services across countries? Postal services is a critical infrastructure that we all use. And so these guys decided to send letters with fake addresses, I think it's hilarious, to 159 countries, and their measure of efficiency was the rate at which these letters were actually sent back to them. They had labeled very clearly in the letter, please send back if not delivered. And so, what should a well-running postal service do? They should send you back the letter if it's not delivered, right? What they saw is that on average, only 60% of letters returned, and they took on average 6 months, which is quite a bit. But there was big heterogeneities across countries. When they studied what determined this heterogeneity, I think they found a couple of things that are really interesting. First of all, it doesn't look like more corrupt countries were more or less efficient in delivering the mail, which sort of makes sense because the mail is not one of these sectors where you think of, I'll bribe my mailman to deliver the post or not. But interestingly, what they found is that the different quality of the postal service seemed to be related to aspects of the organizational structure of the postal services around the world. And in particular, one key element was the extent to which bureaucrats were recruited in a meritocratic fashion, which is one, if you remember, it's one of the aspects of management that we consider as important, one of these basics that we consider as important for the management of organizations. It wasn't so much an issue of differences in wages, but it really does matter how you recruit your people. Perhaps as a counterexample, and this is more recent evidence that has sort of extended this line of inquiry to bureaucracies, Imran Rasool and Daniel Brugger in 2013 implemented this WMS work management survey across 4,700 projects in 63 organizations in Nigeria. And the interesting, the sort of goes a little bit the spiel that I've given you so far, but in their data they found that increases in the management score actually reduced the performance, which in their paper is the successful project completion, whereas a key factor for public sector efficiency here was the level of autonomy that was provided to the civil servants. And the way in which they make sense of this result is that in the Nigerian case, having a very tight monitoring of objectives and compensations that were linked to objectives actually created distortions of attention. And so the bureaucrats, rather than doing their job, they were basically doing things that were easy to measure and easy to compensate. Whereas, again, they say that autonomy and the extent to which these public servants were given the space to make decisions, recruit people, and sort of allocate resources as they saw fit is something that really played well to their intrinsic motivation. So with intrinsically motivated agents, they say they will self-regulate, give them the space to do what they think is good for the organization rather than putting this big bureaucratic machine on their shoulders that just measures in a way that may not be sometimes useful what they do. So I wanted, yes?
Sorry, there are some studies that shows that view of how fair are incentives differ dramatically across countries.
Mm-hmm.
Particularly there is one that compared Berkeley students with students in Kenya or something like that.
Yeah.
And so the question is, to what extent maybe what their result is picking up is this difference?
I think it's actually possible because, especially when it comes down to monetary incentives, the disparity in payment can be a tremendous demotivator, right? So there are other studies that have shown, demotivation within the Berkeley professors and all that. And so I think, this is a possibility here. I don't think it's the full story because they also measure things that are not necessarily related to monetary incentives. It's also the targeting and it's, the accountability vis-a-vis their bosses that matters, is as powerful as monetary incentives. But I think your comment suggests a really important point, which is the fact that sometimes the adoption of these practices, which might be very neutral, right, from the outside, actually clash with the beliefs and the attitudes of the employees. And so it's very hard. We'll talk about it in healthcare in a moment, but it's very hard to just say top down, I'm going to change how things are done today, because effectively you are imposing a new mindset and a new system of beliefs on your employees. And these frictions are often ignored. Now, focusing on the work that I'm currently doing in healthcare, and as I said, other people are currently doing in healthcare, it's a subset of these public sector organizations. Clearly, a very specifically hospitals. I mean, how many of you have had an interaction with a hospital in their life? Come on, right? I mean, you were born in a hospital, probably, right? So that's it starts there. Okay, yeah, you're very posh then. Okay, so hospitals, as I said, we all. Pretty much all of us at some point, unfortunately, have to do, for happy or bad reasons, we have to interact with a hospital. Now, I think a fascinating line of research in healthcare has for some time now documented the fact that actually hospitals, although they look as if they do exactly the same thing, right? What should they do? It's a production function of health. They should take sick people and make them better. Well, actually what happens is that their ability to do so is tremendously different across hospitals. And so just to give you some numbers here, one of the measures that health economists really love working with, economists, as I said, are problematic people in many respects, right? So this will exemplify why. They love working with heart attack mortality rates. Okay, why is that? Well, that's because once you experience a heart attack, you're typically taken to the closest hospital where the episode happened, right? And so focusing on that measure is something that takes into account the fact that there is an endogeneity of choice of the selection of the hospital where you want to be treated. When you have a heart attack, you are taken to the closest hospital typically. And so that's one reason. And the second reason is that the ability of a hospital to deal with a patient that has experienced a heart attack doesn't depend very much on technological innovations. It's not something that requires rocket science, but it requires a few coordinated steps that are relatively low cost, providing aspirins or making sure that the patient is swiftly transferred where he or she should be. And so it's a measure that it's a clinical outcome that depends to some extent on the efficiency and the coordination abilities of the hospital. And so what you see is that, for example, even in the United Kingdom, which is a developed country, there is a variation that goes from 27% of death rates, so 27% of patients dying of heart attacks after being admitted, to 17% in the bottom decile. And this is, controlling for the severity or the specific characteristics of the patient. These are very large variations, right? And these variations in principle should not exist. Similarly, Amitabh Chandra and co-authors have shown that there is a similar dispersion in survival rates from AMI and a broader notion of efficiency of hospitals within the United States. And there is a lot of work that comes from the group at Dartmouth that has made this point for a long time.
So this is a persistent variation.
Then
in any single point, of course, even if you control, there is a variation. But over the years, you see this difference persisting.
Yes, yeah. This is, a lot of the work from the Dartmouth Atlas, which basically takes Medicare data and collates them and builds these panels over time, shows that this variation is quite persistent, right? And the dispersion here, this is putting together just to compare. The yellow line here, the orange line there is a description of the variation in TFP that you find in concrete plants. This was Chad's paper that I mentioned on the first day, and they overlay that with the measure of TFP that they developed for hospitals. And you can see that the magnitudes are actually comparable, right? So there is a ton of dispersion in efficiency across and clinical quality across hospitals. I think there is a little bit of evidence that has recently tried to understand where do these discrepancies come from. Some of this work is cross-sectional, still really interesting. For example, recent work by Joint and others shows that there is essentially a ton of variation in managerial pay, but that variation doesn't explain why one hospital is more efficient than the other. So managers are paid differentially, but it doesn't seem to correlate with hospital performance. Other recent papers have looked at variation in pricing. Other papers have looked at a fascinating paper by Adam Sakarni actually shows that hospitals are quite inefficient in making good use, in maximizing their revenues. At some point, he studies a discontinuity, the adoption of a change in coding that would have allowed hospitals to make more money. And he shows that actually some hospitals were able to jump on that opportunity immediately, and other hospitals just had lost the opportunity to, it's not how I think about US hospitals in general. It's not profit maximizing, but that's what he finds.
And how is this correlated with death rates?
Well, it correlates with our measurement of management scores. I don't know if he has looked at death rates.
That would be interesting.
Yeah, for sure. I'm sure that he's done something like that. I just don't remember whether he's done it in the paper. I think for us, or especially, the issue is that a lot of these papers are super interesting and incredibly valuable, but I really wanted to go deep into this idea of how do we manage care? Because at the end of the day, that's where all the magic happens, right? That's why some patients are surviving and others are not. So using the management survey in a hospital context required a little bit of adaptation of, how do you get at this issue of how do you manage care? As I said earlier, we decided to use a very similar approach, focusing again on basic questions that had to do with the lean operation, monitoring the operations, targets, and incentives. Exactly the same methodology applied again at the middle level of the organization, in this case, chief of services for mostly orthopedics and cardiology. We spoke with them over the phone for about an hour, and again, the same technology of using highly motivated and persistent MBA students to run these regressions. The MBA technology is phenomenal. It works very well, especially once there is a pay-for-performance component. But it's something that led us to a large sample of interviews. And just to give you a sense of how we adapted the survey, we have one question that speaks to these issues of lean, so how the patient flow is organized. And there is a very clear difference once you work in a hospital that maximizes this or thinks proactively at these issues of patient flow. Hospitals that think about it have configured the hospital in a way that people can easily get to the tools that they need, the material that they need in order to treat the patient. Whereas hospitals that are not really careful or don't think proactively about these issues, basically, the ward or the operating room is not. They don't think proactively about what's needed in order to cure the patient. And this actually can have tragic implications for a patient. I want to give you one example that comes from the NHS. This is the UK hospital system. Patients that were treated on a ward in which the towels that were needed to treat or to serve the patients were not located on the same floor, but were located on a different floor. Okay? A nurse needs to go up to a different floor to retrieve this material. In that period that the nurse is absent, the patient dies. Okay, so these are things that seem trivial, but are actually quite consequential once you have to provide care. And so that's one aspect that we care about. Another aspect that we measure, and that's an example of a process improvement in a hospital. This is something that we took from Virginia Mason. It's an organization that I mentioned on day one, very careful about management of their own operations. It's an intervention, a lean intervention that they did. This is a shadow board. So this is an anesthesiology shadow board, all the tools that you want to use to provide anesthesia to a patient. I just want to poll the room. What do you think of this board? What does it look like to you?
Mess.
Sorry? Who said a mess? Yeah, a mess, okay. This is what it should look like, right? Once you do this type of interventions and you clearly label where things should be. Somebody asked me on day one if there was a technological component behind management. Well, you can see this is not something that requires technology, right? This is something that just requires you sitting down and having the discipline to label things and understand where things should go. And so this is one of the, a place that would have that type of organization or that type of thinking behind the way in which things are organized would typically get a high score on our survey. Okay, so I hope that these examples give you a sense of the differences between manufacturing and healthcare. In other aspects, we kept exactly the same questions. For example, asking about performance reviews, whether hospitals paid attention to reviewing the performance of their employees, which may be doctors or nurses, or whether they basically neglected that aspect of human resource management. So some of the questions capture this too. This can be actually tricky to measure in hospitals, especially in the US, because what we notice is that in US hospitals, often doctors have no say on these HR practices. They're completely detached from the HR aspects of the hospital. As I already showed you this graph of what a performance monitoring would look like, this is just putting data on a board, but fundamentally it requires having the willingness to meet regularly and discuss what's happening, being open to discussing both successes and, most importantly, failure. And I think that that's a critical obstacle here, is that in many organizations, the management and to some extent the employees just don't bring up the failures. The problems don't arise and there is no discussion, productive discussion around them. So the data that I'm going to show you in a while covers, started with a pilot that we ran in 2006 just in England and Wales, which was limited to the NHS. And then in 2009, we repeated this data collection and extended the data to 2,000 hospitals, including both developing and developed countries. Some of the things that we notice map the distinctions that we see also in manufacturing. In particular, we see that there is a wide discrepancy in the adoption of management practices across countries. And let me say, as a disclaimer, this is the only graph where I see the US coming out on top for good reasons in healthcare. Okay? Usually there is a big discussion of the US health system being inefficient or costly or lots of issues. In terms of the management of hospitals, which is one piece of the healthcare system in the United States, it's more advanced than other countries. And you can see some large differences also with Brazil and India, which are two developing countries in the sample. And then similarly to manufacturing, big differences within countries, big differences in management practices within countries in hospitals. Once we look at the relationship between management and clinical outcomes, what we have observed for the sample of hospitals where this information was available, it's not as easy to get a performance data for hospitals as it is for private sector organizations, is that higher level of the management scores correlate with lower levels of mortality rate. So in the cross-sectional correlation, the quality of management correlates with the quality of this specific clinical outcome, which is the heart attack survival rates. Obviously, if you are empirically trained, you should be skeptical in the sense that this is a correlation. So we don't have an experiment in this sector yet. And also another aspect that is not covered now, but I hope to develop in the next few years, is that hospitals are multi-product organizations. And so it's not clear whether being good in terms of heart attacks might also map into being good in other outcomes. So there is a lot of work that needs to be done there. But I think it's encouraging to see this as a first cut of the data, which is replicated also across different measures. For example, this is relationships that we could estimate for the UK, where they put a lot of attention in measuring the performance of hospitals. We could find also correlations, better managed hospitals being places where people don't want to live as much. So lower rates of intention to leave of the staff, which is a critical HR measure. And to some extent also this higher levels of these ratings that the government provides. So I think that this is suggestive that management does seem to matter also for clinical care, with much more work that needs to be done here to look at the causal relationship behind this. to me, I think that the place where I hope that this, where we're starting to do work, but and I hope that this will be relevant from a policy perspective, is how do you close the management gap in healthcare? So if you take for a moment, we know that there is variation. This variation seems to be relevant for clinical outcomes. To me, the critical question is, what do you do now, right? How do you close this gap? And so the topic that I'm not going to cover today, but I think is really relevant, is this issue of competition, especially in the United States. And thinking about the ways in which competition provide incentives for improvement. I think this is super relevant, and there is work that is currently ongoing there. The two pieces where I want to focus in the next 10 minutes or so is this idea of choosing the level of the hierarchy of the hospital where to intervene. And in particular, I'm going to show you some work that we're doing that focuses on the training that is provided to middle managers, and in particular physicians that have managerial positions. And the second one is focusing instead on top management, and in particular the allocation of different COs across different hospitals. So it's two different types of change. One is top down, and the other one is more bottom up. Yes.
Well, a question. So this is a rather optimistic view of management, in a sense that you can offer incentives, or to some extent you can change it. You can maybe because I'm from the south of Italy, you can also have a rather negative view. More it's about culture and institutions and things that are time invariant. It doesn't matter how long you. I mean, in a sense, changing the culture. I mean, given that as you present, management is also a matter of interaction between people.
Yeah.
And so some of that, could be that could be hard to measure, hard to identify, but there could be cultural elements that limit to some extent discussion of negative cases. I mean, would that be first? I'm not really sure whether there is research on that, and second, do you think that would be a concern in a sense to have an incentive-based view?
So you're spot on in the sense that in order to do the analysis that you just suggested, you need to look at the persistence of what Luigi was mentioning before, right? And I think that there is evidence showing that the performance of hospitals is quite persistent. I'm going to show you something about the UK in a moment. So it's true, there is definitely much more inertia in a hospital than I think there is in a firm. So this is a constraint. Now, having said that, and this, you're right, I'm an optimistic. I've also seen stories of change. Right? And the example that I provided before, which was this Virginia Mason hospital, there are other hospitals around the countries, and I think that there is a set of circumstances, a set of combination of decisions that can actually lead to change. So I'm optimistic in the sense that I've seen it happening, and I think it's possible. I am a little bit pessimistic in the sense that I don't know whether we know how to characterize all the levers that need to be pulled for that change to happen. But that's where research is needed. And so I'm going to show you something that I hope will help inform that type of discussion. Yeah. So starting with middle management, one of the shocking things about hospitals is the fact that typically the promotions to this, first of all, middle managerial positions are critical. That's a lot of the critical decisions of the hospitals are made there in terms of allocation of resources, allocation of people, resolution of problems. Don't think about the C-suite too much. I mean, that's important, but a lot of decisions depend on middle managers. The second piece, that's the shocking piece to me, is that often the selection to the managerial position doesn't really depend on the managerial quality of the person, on the managerial skills of the person. What happens, and not everywhere, but I'm generalizing, of course, is the fact that sometimes it's your clinical ability or your, even your willingness to take on the position. It's not easy to find people who want to take these managerial positions, maybe for good reasons, but that's how promotions are made. And, the other piece is that it's, although hospitals are sort of trying to, especially in the US, they're trying to close these gaps providing managerial training once people are promoted, providing onboarding. I think there's still a lot of gap between the deep clinical skills of doctors and their managerial skills. Though these people are called to coordinate people in complex environments, often under situations of extreme pressure. So recently, this paper by Chris Myers, who is at Johns Hopkins, and Peter Pronovost, who is one of the key leaders of the quality improvement movement here in the United States, they make this point in, I think, an interesting paper, where they even say, we should make management skills a core component of medical education. When you go to medical school, you shouldn't just learn about the basics of anatomy and all that, but you need to learn how to coordinate and manage people. So this is a statement that they made. I'm going to show you some data that I think supports this idea. In particular, once we analyzed our own data on the differences on management across hospitals, what we saw is that there was variation across hospitals in the extent to which these leaders, these middle managers, were trained in terms of had been exposed to managerial programs. And we're not just talking about MBAs. At least at HBS, and I don't know how it is here, we have an MD MBA program, but typically people who go through that program then end up being in administration. They don't go back to clinical practice. But also shorter managerial programs that might be shorter and sort of more light in content. And what we see is that this element of training is strongly correlated with the quality of management practices, and it's also correlated with the clinical quality provided by the hospital. So we tried to look at at some more causal analysis of this relationship, and what we exploited is the fact that hospitals differ in the extent to which they are exposed to schools that provide both clinical and managerial training. And so that element of, that changes the supply of clinical managers with training. We used it in our analysis, and it seems to suggest that this element of education and skill provision might be an important lever to consider. The second piece of the work, as I said, rather than focusing on middle managers, goes to the top. And so, as I'm sure you know, there is a vast literature, and there is a lot of interest in understanding what CEOs do and how they affect their performance. There is work that originated from here, actually, with Marianne Bertrand and Antoinette Chouard, that tried to estimate the persistent effect that CEOs could provide to the organizations that they managed. Other work, again, I think Chicago has a little bit of an obsession with CEOs now that I look at it. Even Steve Kaplan, other people, have done some work on how CEOs spend their time. But, it's these ideas that, at least in private sector organizations, who runs the show has an effect on the performance of the company. And as Nicola was mentioning, maybe I was talking to you earlier, this evidence is starting to build also for the public sector, in particular the persistent effect of principals in schools. There is, however, no evidence on the effectiveness or the importance of hospital CEOs. There is a little bit of cross-sectional evidence, but no evidence that looks at the persistent effect in sort of winning this inertia that we just discussed about hospitals. So what we did, we took the English NHS, the National Health Service, which is effectively a mega firm. The NHS is the 5th largest employer in the world. And the way in which the NHS thinks about leadership is inspired by this movement of new public management reforms that started in the early 90s, in which the responsibility of general managers is actually quite important. So they think about general managers, and they train them also with the idea that they would be able to create accountability and change the ways in which the hospitals were run and the performance of the hospitals. So we sort of took this idea. I mean, this is based on the belief that general managers matter, but we wanted to see whether that was true. And so what we did is we analyzed a panel of 472 CEOs, which were tracked across 14 years, and the population of NHS hospitals. and looked at two things. First of all, how are these managers compensated? And are there persistent differentials in the compensations of these managers? Why is that? Because that's how the market perceived them. It's a measure of how the market whether the market perceives that these managers have differential quality. But second, we looked at a battery of 22 outcomes that we could retrieve for these hospitals that range from clinical outcomes, financial results, productivity, staff satisfaction. And we exploited the fact that these managers rotate across hospitals to disentangle what is called the hospital fixed effect, so the persistent differences in performance that you were mentioning a moment ago, from the CEO fixed effects, which is the difference, again, the persistent difference that a manager can make to the organization that they run. And what we found was frankly quite depressing, in the sense that we found that there were very large relative to the public sector and systematic and persistent differences in pay across CEOs. So it seems that the market perceives CEOs to be qualitatively different, which sort of, at face value correlate with the characteristics of these CEOs. When I knew that this data was realistic is when I saw that there was a negative coefficient on gender. So female CEOs being paid less sort of maps what's happening in the labor market more generally. But unfortunately, however, these differences in pay are not matched at all with what we found for performance. And so what we find with this data is that basically there is no evidence that CEOs can persistently change the performance of the organizations that they run. A hospital may do well a CEO may do well in one hospital. That person changes the context. It's very hard to replicate, very hard to leave a persistent mark on these organizations. So I think that this is, in a sense depressing, but in a sense, I think the real message here is that if you want to change the way in which these complex, inertial organizations are run, it's probably very naive to think that top-down change in a matter of few years will be able to lead to some systematic differences. So how can change be engineered? And I think that that's the question where I have hope, but definitely requires much more research. My sense is that here, with the caveat that we should extend this analysis to a system that is not single payer, so perhaps the US would be a nice context. We cannot think about rapid turnarounds in healthcare. It's really unrealistic to think about rapid turnarounds in healthcare, according to this data. I think that we should think about longer change, situations in which the CEO perhaps also changing the type of powers that are given to the levers that they have in their hands to reallocate resources and change people, but it requires a much longer run approach and critically also the ability to bring with you that middle managerial level that is often very skilled, very competent, but often completely detached from the organization. So in terms of future work, and this is where I'm going to leave you, I think that the big next step here is next year, hopefully in cooperation with the census, we're going to extend this data collection to the population of US acute care hospitals so that we can have a much better picture of the variation around the country and the correlates of this variation. And this is something that will also help us understand, I hope, more about this the effect of consolidation and changes of ownership on management quality and clinical outcomes. And the dream, obviously, is at some point to be able to run an experiment that involves the provision of management training to doctors that would involve a randomized controlled trial. So I'm going to leave you here with sort of wrapping up these 3 days, and then we have 10 minutes for questions. But I hope that this series of lectures has exposed you to the idea that studying management, first of all, that management matters. I hope that that's at least one method. The second is that I think we can be much more scientific and much more rigorous about the study of management and how that affects performance. Having said that, there is so much here that needs to be explored. First of all, I think we have some hypotheses and some evidence on why this dispersion in management quality exists. But we really need to have a priority, right? Understanding what are the levers that need to be changed first. Second, fascinating question that somebody raised, I think, on the first day, is this issue of, can we think about management as changing? Maybe the optimal practices change according to the nature of the age of the firm. What works in a startup clearly would not work in mature firms. We need to understand much more about these contextual differences. What type of management practices, how do they relate to each other? Are they complementary? Is there something that matters more than others? I think the key question is understanding the role of leaders and cultures. And critical question, how can organizational frictions be reduced in the public sector? So these are all questions that we still have to grapple with. If you're interested and you want to go deeper, there are some overview articles on HBR. We have a website where we put all the academic papers, all the data. You're welcome to use them. You're welcome to use our methodology and just run your own survey if you want to. And then finally, just leave you with a couple of quotes that we collected during the hospital surveys. This is the challenges of running surveys in India. The interviewer asked, do you offer acute care? The switchboard, yes, madam, we do. Do you have an orthopedic department? Yes, madam, we do. What about a cardiology department? Yes, madam. Great. Can you connect me to the ortho department? Sorry, madam, I'm a patient here. All right. Thank you very much, and we have some time for questions. Yes?
Do you have any results from the management training RCT that you mentioned, or is that something in process?
So this is something that it doesn't exist yet. I think I think this is one of the important next steps, yeah.
And one of the issues I've seen in my career is the durability of change.
Yeah.
And the fact that you can get any organization that's under crisis and stress will change.
Right.
But it's never durable, and you can just in areas such as hospital efficiency, operating costs. It's very easy to go in and get a very significant reduction in operating costs, but inevitably, 5 years later, the performance is back to where it was before.
So, I mean, there is a reversion to the mean, right? In every private sector and public sector organizations. That's just what you observe. So getting that sustainable gap in performance is hard regardless of where you look at. I think what I noticed in hospitals is the fact that often there are significant changes that happen in some pockets of the organization, and you have some really motivated people that are able to change things for some time, but then inevitably they clash with the center of the organization, and these inputs for change die down. And that makes me angry. Because in a sense, you have so many intrinsically motivated people and capable people that propose these changes over time. I think it's an administrative failure not to be able to receive them and make something out of them. And I think that's a really big problem. Yeah. All right. Yeah. Please.
Getting back to this durability issue, I worry about the Hawthorne effect. That when you're looking at a group and you're training them, there's a lot of focus on these managers, and they're changing, they perform well, but like the Hawthorne study, once the light was off of them, they revert quickly to old behaviors.
Yeah.
And how much, as you're measuring all these management impacts, how much is this, do you think, it could be a Hawthorne kind of effect?
I don't think that, so in our case, I think one concern you might have is that people answer, the equivalent of the Hawthorne effect is that the type of answers that we get are biased and people just say what we want to hear. I don't think that we have that issue. These are noisy measures, but I think that they're realistic measures for all the efforts that we put together at reality. I think it's definitely a problem once it comes to designing an experiment. right? And there you can take care of this, I think, designing the proper control group and making sure, you can get much more about the mechanics of change once you do that. Yeah. Yeah, please.
Training. When we talk about training for middle managers, what kind of training are you thinking about?
So, I think that here, I have not run the experiment yet, but I can tell you what my ideal experiment would be like. I would focus on the most basic stuff. For example, being able to listen. Now, I don't know if you're related to doctors or if you talk to doctors. My dad was a doctor, okay? And I loved him to death, but he wouldn't listen, right? So, I think, I give a concrete example. Doctors interact with nurses. Nurses know what's really happening on the ground and they raise issues. But because of problems of seniority and hierarchy, these inputs is often ignored. So I think that a first step would be how do you sort of close these hierarchical gaps so that you have a better flow of information? That would be one. I think two could be even have an agenda when you meet and have a follow-up plan. Again, in these interactions that are often structured in the way in which clinical managers work, they have to meet weekly. For example, surgeons meet weekly for the morbidity and mortality to discuss what happened. But often there is no agenda and there is no follow-up plan. And so a lot of the decisions just die there. A lot of the issues die there. So I think you can really start with something as basic as that. You had a question?
You mentioned in the NHS study the 22 performance outcomes. Do you have any data for US hospitals and how they compare to the UK ones?
For the hospital outcomes, you mean?
Right.
Oh, yeah, there is a lot of research on hospital outcomes for...
Right, so you showed the graph where the management practices in the US were higher. Was highest. How do the US performance outcomes compare internationally?
Oh, I see what you mean. Yeah, so it's a critical question that unfortunately I think it's hard to measure because the clinical outcome, some people have tried to do that. I don't think that the US gets out very, it doesn't typically show up as a high-performing country, to say the least. But it's very hard to compare apples to apples. So I don't know whether, for example, we can compare the AMI mortality rates of US hospitals to the AMI mortality rates of UK hospitals in a convincing way right now. There's still so much to do on cross-country comparability of hospital performance. I'm sure that there is a lot of work that is being done now, but I'm not aware of studies that have done this comparison reliably at the hospital level for the same condition.
We don't know if the management practices are useful for anything without that other half of the study.
We know that we know that within the US, management and clinical outcomes correlate, and we know that for the UK they do the same. But I don't know whether on aggregate one country is better than the other. Yeah. Is that a hand? A half hand? Okay, I'll take it.
Yeah.
Go ahead.
So concerning public sector employment in Italy, for example, I think there's some other Mediterranean countries where kind of management practices seem inefficient, but that serves kind of as incentive to try to get that position because you can't get fired once you're in.
Oh, yeah. Yeah.
So I guess I was wondering if you have that same kind of system in Italy and if you think you can kind of account for that.
Yeah, so you're pointing to a really important problem, which is you're absolutely right. To some extent, these are jobs for life. So recruitment and especially firing underperformance or retraining underperformance is a major obstacle. So when I was describing the data before, I was telling you that there is, for the public sector, the country component accounts for a larger portion of the variance than it does for the private sector. These are exactly the type of institutional features that play a role here. So HR management would be, incredibly conditioned by these, country-specific features of the institutions. Having said that, even within the public sector, you see variation, right? So it's definitely something important, but I don't think it's the end of our hopes, if you like. Okay, great. So thank you very much, everybody. Thank you.